Good evening, friends. On behalf of Delhi Orthopaedic Association, I welcome you all to our 5th episode of Trauma Series on Elbow Trauma. The topic chosen for the deliberations are very relevant in our day-to-day life, and they will help us to better understand the assessment and the management of these simple and complex elbow trauma. We are honored to have Dr. Kotwal sir, who will chair the session, along with our distinguished speakers, Dr. Deepak Jain, Dr. Dhananjay Sabat, and Dr. Samarth Mittal. In the end of the session, we will have some case discussions by Dr. Samarjeet Singh and Dr. Harpreet Singh. I take this opportunity to thank Dr. Pushkar for organizing this meet, and he will also moderate the session. I once again welcome the faculty members and the delegates, looking forward to a very fruitful learning experience. I request Dr. Pushkar to please start the proceedings. Dr. Pushkar, please. Thank you.
Thank you, Atul sir. Thank you, Shekhar. Thank you, organizing team from the DOA, who has really worked hard and working daily throughout the years to give us few learning experience from our home comfort and giving us an opportunity to discuss and see difficult case scenarios also from their home comfort only. I thanks Dr. Atul and Dr. Shekhar once again for giving me an opportunity to moderate this session on elbow injuries. I welcome you all once again, because without you, it won't be possible to do this. Without much delay, let's start the session. I first humbly request our Professor Dr. P P Kotwal sir, who has always smiling, soft-spoken image, but highly knowledgeable with experience of working at AIMS. He has a special interest in upper limb, we all know. We like to hear from him a few pearls in the last from his experience after listening all these speakers and case discussions. I welcome Dr. Professor Kotwal sir as chairperson to this session.
Thank you.
Professor Kotwal sir.
Good evening, everybody. Thank you, Pushkar, for giving me this opportunity to join this webinar and maybe interact with all of you. It would certainly be a learning for me as well. I also appreciate the initiative taken by Pushkar and by DOA for organizing this webinar, particularly on elbow, which is actually at times a simple, but more often it's a difficult proposition that we come across in our practice. So without wasting much time, I would certainly start with this thing. And Pushkar, who is the first speaker? He can be invited.
So before start the sessions, so it's a 10 to 12 minutes in talk and 2 to 3 minutes for small discussion related to that topic only. And we have chosen topic from very simple topic, simple dislocation elbow or fracture dislocation or radial head, keeping in mind for the help to the daily practitioner in our DOA meet. So please take control of your talk about 10 to 12 minutes only, so that we can take a few questions. And this is a time when other speaker can put his presentation ready. So in the last, we have 40 minutes for the case discussion, where we all can participate there. And finally, a few practical tips. So with the permission from the chairman sir, let's start and give a mic to Dr. Deepak Jain. Dr. Deepak is our first speaker. Dr. Deepak.
Yeah, very good evening to all. Am I audible?
Yes, Dr. Deepak Jain, his dad is MS from Maulana Azhar Medical College only. And he's working now at Dayanand Medical College, Ludhiana.
Yeah, is the screen visible to all?
Yes, Dr. Deepak. Visible.
Okay.
Just a minute,
okay,
Doctor.
Thank you.
Dr. Deepak, it's my time to introduce you.
Thank you.
He's professor at Dayanand Medical College. He has done multiple international fellowships. He has special interest in arthroplasty, sports medicine, and complex trauma. I welcome Dr. Deepak again, and we have given him the most difficult topic for the day, the simple dislocation elbow, how to assess and plan. So I welcome Dr. Deepak. Please start your topic. Thank you, Dr. Deepak.
Okay. Thank you. Thank you very much. Is my voice clear? Am I audible? Okay.
Yeah,
thank
please
you.
Go ahead. You are audible.
Okay. Thank you. I thank the Delhi Orthopaedic Association for giving me this wonderful opportunity. Did my graduation and post-graduation from MC, spent 10 years in Delhi, so it's more of a homecoming to me. And working with Dhananjay and Harpreet in our post-graduation days, so brings back so many memories. And I thank you for giving me the topic of elbow dislocations. We will start by looking at the concept of elbow stability. What are the structures which contribute to it, the pathoanatomy behind it, and how to go about doing the conservative management of elbow dislocations, when to operate, what to do. We'll try to look at that. And in the end, we should be able to know that the elbow dislocation is not so simple. So that if we are able to get that, then I think my message is across you. So the simple elbow dislocation has been described as a pure dislocation where there is no fracture millimeters. Elbow happens to be the second most commonly dislocated joint in the yes, please. Am I audible? Any problem there?
Problem initially, now it's clear.
Dr. Deepak, there is some issue on your side, I think. Your voice is not clear to us. You are not audible.
Is it? Is there a problem with the voice?
Yeah, now it's clear.
Hello?
Yeah, now it's clear.
Okay. Okay. So let's start with the relevant ligamentous anatomy. On the lateral side, we have the lateral collateral ligament, which is composed of the three parts. The anteriorly, we have the radial collateral ligament. Then we have the annular ligament, which encircles the radial head. And most importantly, the third most posterior, the lateral ulnar collateral ligament, which starts from the postero-inferior part of the lateral epicondyle and is inserted on the supinator crest of the ulna. So this is the major contributor for the posterolateral stability. On the medial side, we have the medial collateral ligament. So this is composed of the anterior bundle, the transverse, and the posterior bundles. So, but the anterior bundle, this is the key valgus stabilizer. And if we resect this anterior bundle, it can lead to valgus instability. So studies have shown that supination provides stability of the elbow in the MCL deficient elbow, whereas pronation stabilizes the LCL deficient elbow. So we can use these knowledge once we are immobilizing the elbow after shoulder elbow reduction. So we can use this. So coming on to the concept of elbow stability, the elbow has been compared to a fortress, and the stability is derived from static as well as dynamic stabilizers. The static stabilizers are further divided into primary and secondary. The primary stabilizers include the ulnohumeral articulation, which contributes to 50% of the stability of the curvature of the olecranon provides stability in extension. We've already discussed about the anterior bundle of the MCL and the LUCL, which are the other primary stabilizers. Apart from that, we have the secondary stabilizers. Contact area here increases inflection. Apart from these, medially we have the common flex pronator origin here, and the common extensor dynamics which transcend the elbow, anteriorly biceps and brachialis, and posteriorly we have the triceps. So O'Driscoll in 1991, he proposed the valgus external rotation theory to explain how the elbow dislocates. So it starts with the fall on the outstretched hand, and as the elbow is flexed, the arm and the body are in relative internal rotation, and the forearm is in relative supination, and there occurs axial compression, and a posterolateral force is generated, which leads to posterolateral dislocation of the elbow. So if we see the soft tissue disruption, it progresses from the lateral to the medial side, first involving the lateral ulnar collateral ligament, the LUCL, and then extending medially across the capsule and reaching the medial side, the medial ulnar collateral ligament, thus completing the Horace circle. So this is what we have been traditionally taught. However, a newer mechanism of injuries have been proposed. Schreiber in 2013, these authors, they analyzed the online YouTube videos which showed elbow dislocations in real time. They studied the impact videos and how the deformity occurs, and they proposed the valgus hyperextension theory. And they said that once there is a fall on the outstretched hand, then the elbow gets locked in hyperextension and the MCL gets torn first, and then it progresses laterally. So once the MCL is torn, it leads to disengagement of the coronoid process and further leading on to posterolateral dislocation. So there is again a continuum of injuries which goes on. So the elbow dislocation, it can either be posterior or posterolateral, which is most common, more than 80% of the cases. The other directions are relatively quite rare. The posteromedial, divergent, anterior, or pure lateral or medial are quite rare. Coming on to the clinical presentation. So we usually have a fall on the outstretched hand, and the patient presents with a deformity. Elbow is in a flexed position. The olecranon is prominent. The triceps tendon is also prominent, and we can appreciate a. If we see lateral bruising, that is suggestive of a severe injury and a hematoma. We need to examine the neurological and the vascular status. And usually we are able to lateral and oblique X-rays of the limb. So what is the role of MRI? It is still evolving. We are not sure which cases to subject to MRI. It has its role in severe cases, which disruption is going on, and it can pick up subtle subluxations also. However, studies have documented that there is a risk of over-treatment, some soft tissue disruptions on both medial and lateral sides. So nowadays, many authors, they are using the stability of the elbow. So if we are having a patient with a dislocated elbow, once we are reducing it under general anesthesia, we can assess it under anesthesia. Or if the elbow has self-reduced, then, and we are suspecting a severe soft tissue injury, then between 1 to 2 weeks of the injury, we can assess this elbow under anesthesia. So the elbow stability is assessed in the flexion extension arc in neutral, pronation, and supination positions. The varus and the valgus stability is also assessed. The angle is measured between the distal humeral joint line and the proximal radio-ulnar joint line on the AP projection. The instability has been defined as mild if this angle is less than 10 degrees, moderate if it is more than 10 degrees, and if the elbow redislocates during the examination, then it is defined as gross instability. So studies have shown that if the patient has moderate or gross instability, then the results of conservative treatment are worse. Now coming on to the next step, once we have reduced the elbow, then the next question arises is how much for how long we have to immobilize it. One thing which is clear in literature is that immobilization more than 3 weeks results in residual stiffness and residual pain. And there have been studies which have compared early immediate mobilization and brief immobilization of 3 weeks plaster, and there has been no long-term difference in the outcomes. So the duration of immobilization needs to be less than 3 weeks. It can be 1 to 3 weeks depending on the severity of injury. And we need to immobilize it in 90 degrees of flexion and assess in which kind of rotation the elbow is maximally stable. So once we start to mobilize it, it is mobilized within the stability arc with the pain which the patient can tolerate. And it is also how much, if there is some residual instability, again, the patient will be mobilized within the stability arc. And other time, the patient can use a cuff and collar. We increase the extension weekly and also need to take serial X-rays if severe injury is suspected, because there can be subtle dislocation or redislocations. So overhead rehab protocol has shown good results. This is the position in which the elbow mobilization is done. The advantage is that the effect of gravity is neutralized, and the triception, so extension as well as pronation supination exercises are done in this position. So what have been the outcomes? So there are a lot of studies which have compared, which have results in majority of patients. So the issues which remain are residual stiffness and pains, again reported in 30 to 50% of the cases, but probably they are not that bothersome to the patients and can be minimized by initiating early motion. Residual instability has been reported in 2 to 8% of the series require surgery. And again, this can be minimized by initiating active motion protocol in a timely manner. Very few of these will require surgery if it is persistent. Dislocation is again an issue, recognize it and on the serial X-ray, and if it is there, needs to be treated surgically. Coming on to the surgical management, it is usually required in less than 10% of the case after a reduction. But assessment of this instability is still a gray area. We are not very sure which injuries are actually needing, which will be actually helped by doing an operative intervention in the early phase. Currently, the recommendation is to, if we have moderate or gross instability under examination under anesthesia, then we should go for operative repair, or if the elbow dislocates in less than 30 degrees of flexion, but still literature on this is evolving. The other indications for operative interventions are quite rare. So what do? We approach the elbow either through the posterior midline approach or the paired medial and lateral approach. Traditionally, it has been and repair it using the transosseous tunnels or suture anchors. Once we are done with the lateral side, then we again assess the stability, and if it persists, then we go ahead with the medial stabilization. But now, and examination under anesthesia, it has to be tailor-made according to the patient's pathoanatomy. If it is still unstable, then we have a fixator may be required. So the take-home message is there is a subset of patients which have high-grade soft tissue injuries, which need to be where we need to be very careful of. Most of these patients will do a set of severe injuries. We need to be very careful, do an MRI and examine these patients under anesthesia. Moderately unsurgical treatment is recommended, and we need to go in for the lateral side first. So future studies are again in this subset of high-grade soft tissues injuries. Thank you very much.
Thank you, Dr. Deepak. Thank you. Thank you for finishing within the time limit. So anybody have a question regarding this? Anything by the time Dr. Dhananjay can start taking its time to upload his talk. It was very elaborative, Deepak sir, and you have tried to give a few tips for our daily practice, which will be really helpful, especially overhead rehabilitations for the elbow, for the initial elbow dislocation. So thank you very much, Deepak sir. So
thank you very much.
Sir.
Yeah,
yes, sir.
There is one question from the audience that what's the approach for the unstable elbow and choice of implant?
So again, I have mentioned in my lecture that we can approach the elbow either from a midline incision posteriorly, where we will go both to the lateral side and then to the medial side. So this is, or the other option is paired medial and lateral approaches. So we go in for paired medial and lateral approach. One indication is if the skin posteriorly is not very good, then we might like to do posterior, the paired incisions. The other indication for paired incision is one, if we are sure that we are thinking that one side of the injury, maybe we may get away while doing lateral side repair, then we might not do a posterior, we might do only the lateral one and see whether we may need a medial or the lateral one. The choice of implants, again, it depends. Especially for the lateral side, we can do transocious repair if the suture anchors are not available, and it's not a very difficult technique. We just need to be knowing the basic pathoanatomy, and the repairing part is not very difficult. And if we have the suture anchors, it is again very simple.
Deepak sir, just a point. I personally want to know, because the injury is more on the anterior side, because the elbow has dislocated posteriorly. So how you tackle that anterior part going from posterior, or do you do something?
Yeah, actually, we need to go all the way, starting from the posterior side. We need to go all the way to the medial side and the lateral side. The exposure would be the same, which is there will be the similar on either of the approaches. Either we are going paired approach or the single approach. The exposure which we require, we have to go anterior and assess the anatomy. As you rightly said, the most of the pathoanatomy will be anterior.
So thank you, Deepak sir. So we have short of time. Sorry.
Yeah.
I now welcome my second speaker, Dr. Dhananjay Sabat sir. He is also a professor, and he has recently become a full professor at Maulana Azad Medical College. So we congratulate him and welcome him again. He has special interest in sports medicine, arthroscopy, and difficult trauma. Dr. Dhananjay sir's topic is the most notorious one of the radial head fractures. Let's excise it, fix it, or replace it now. So I welcome Dr. Dhananjay. Are you ready with your talk, sir? Dhananjay sir. Yeah, he's getting ready. Yeah, Dhananjay sir is on the screen. So Dhananjay sir, please start.
Dhananjay, you need to unmute.
Dhananjay sir, unmute please. No, sir. Dhananjay sir, we are not able to hear you.
I hope now it is fine.
Yeah.
Okay. So I'll be skimming through the basics first, so that you have a good hack what recent is happening on this. So it is not moving. So radial fractures are quite common, 20% of the elbow injuries, and commonly in the younger age group, 30 to 40 years. They're easy to diagnose on X-ray, but the plan is complex because there are more associated injuries, and outcome is affected by multiple factors. And of course, elbow have always risk of this myositis ossificans or heterotopic ossification. That's an added problem with an elbow. So the injury patterns of the radial head is supposed to be mostly three types: a valgus load, where there is impaction of the radial head with a rupture of the MCL or medial collateral ligament. The commoner injury is posterolateral rotary subluxation, where there is a shear fracture on the anterior part of the radial head with LCL rupture, or there is axial forearm load, where there is a direct impaction associated with coronoid fractures, even leading to a Essex-Lopresti type of injury. The associated injuries are very common, which can be almost 17% in this study. In type 1 fractures to a quite high incidence in the type 3 fractures. So always that should click into our mind that it can injure the collateral ligaments, the other bones like coronoid, capitellum or proximal ulna, even forearm fractures, dislocations, Essex-Lopresti type of injury where the distal radioulnar joint can be disrupted and there is axial instability. Unless we diagnose these associated injuries early and manage them properly, the results are not going to be great. The clinical evaluation is classic pain and swelling over the elbow, and ecchymosis appears after a few days. And if there is a tenderness over the lateral epicondyle, we think of a LCL injury, and over medial epicondyle, we may think of a MCL injury associated. The range of motion gives an indication that is the forearm rotation is the primary indicator for surgery that we'll discuss again. To reduce pain, sometimes we can do aspiration of the hemarthrosis and inject local anesthesia for assessing this pronation and supination. We always must examine the wrist. That's a distal radioulnar joint for tenderness and ballotment. The common radiographs like epi and lateral, we always do it. If we have any doubt of type 1 fracture, if we see a anterior or posterior fat pad sign, we can get a radiocapitellar view or the radial head view, in which the tube is tilted 45 degree, aiming towards the shoulder, and we get the full radial head in the profile. In case of doubt, we must get bilateral wrist radiographs to document the Essex-Lopresti type of injury. The CT scans are quite useful to see subtle displaced fractures, which is many times missed in the X-rays and other osteochondral fragments. MRI is rarely used, though it can be used in associated collateral injuries. The common classification, what we know, is a Mason, which is quite old. Type 4 was added later by Johnson when there is a dislocation associated. Mori and Broberg, more specifically, they went into the 2 millimeter displaced and more than 2 millimeter to define the type 1 and type 2, 2 millimeter and 30%. This was added by Mori. The later Hotchkiss expanded the Mason classification on clinical basis, whether there is a mechanical block, whether there is no mechanical block. So that differentiates what to do, whether when there is no mechanical block, it is conservative, when there is mechanical block, it is operative. And the next is Mayo-Mason classification, which have some suffixes added. In case of articular injury, a suffix of C for coronoid fracture, O for olecranon fracture, and ligamentous injury, M, L, and D, depending upon the MCL, LCL, or DR is a disruption. So it basically a simple uncomplicated fracture or a more complicated fracture and a secondary injuries, which can further redefine what we are going to plan for this particular case. Like you can see the two diagrams down. There is a type 2 fracture with dislocation, but L and M is lateral and medial collateral ligament. But when there is a coronoid fracture, a C is added. So this is a sort of more complex classification, but more handy and easy to communicate. Non-operative treatment is quite used for the undisplaced or minimally displaced fracture without a block. And even if we see a block, radiographically, there is a block, we can reevaluate the patient. The patient doesn't have a mechanical block, but there is a small depression. We can reevaluate the patient for pronation and supination after some time, or by injecting local anesthesia. So when the partial articular fractures were displaced more than 2 millimeter and involved more than 30%, usually a open reduction and infection is advocated, but there is no comparative study to prove whether it is better than non-operative treatment. Usually the immobilization is as short duration as possible, even 2 to 3 days in some studies, and soon a range of motion should be started on a sling or a collar cuff, and a radiological follow-up should be done at frequent intervals. Usually the outcome is good in non-operative treatment in the proper selected group of patient, but still there can be some complication like terminal loss of extension. And if it is found displaced, then we proceed to the next stage of treatment. The operative treatment have a triad: excision, fixation, and replacement. And they are quite interrelated to each other rather than what I choose to do. And there is a scientific basis to decide what we are going for. So fragment excision or partial excision is also described when there is a small block which is causing a small block in motion, less than 25% of the articular surface, but it is non-reconstructible. Then this can, a partial excision can be done. But if it is a larger fragment, a partial excision can contribute to clicking, painful clicking, or even some lead to loss of the concavity compression and instability in the radiocapital joint. So in those cases, we may think of a full excision or a fixation rather than a partial excision. Partial excision is very rarely used. It can be even done arthroscopic in expert hands. Examination under anesthesia is the critical part in taking a decision, because we can see the associated ligamentous injuries and the stability part, both in the flexion extension arc and the varus valgus directions. Even axial instability can be evaluated. So that is a critical part, should be done before we go in. The classical approaches used is lateral based approach, which have 3 intervals: the Kaplan's interval, the Cocker's interval, and the EDC split interval. The Cocker's approach is the orange line in between the anconeus and ECU. So it is a very small window. So if the LUCL is injured, then this window can be easily expanded for the radial-led procedures for fixation or replacement. But if the LUCL is intact, this window is very small to work. So this should not be used when LUCL is intact. Whereas the Kaplan's interval between the ECRB and EDC, this is a more expansile approach, though there is a risk of injury to nerve by any of the 3 lateral approaches. So most surgeons also prefer the EDC split approach, which have some risk of injury to antebrachial cutaneous nerve or lateral cutaneous nerve of the forearm. Now the second approach is from the posterior side. That's a Boyd's approach in between the ulna and anconeus, that is marked by the pink line. And this is safe because the nerves are nowhere nearby. It can be extended down and can be explored quite down into the radial, even radial tuberosity. So this approach is further modified into another approach. Now it is known as Writington approach, in which there is a small osteotomy is done from the supinator crest, and the annular ligament is reflected out, so that the radial head can actually be delivered out for the fixation or replacement part. So this is a very safe, easy, and effective approach, hence now getting quite popular. And the scar is also posterior side, more cosmetically acceptable, though it is larger incision compared to the lateral approaches. But it's a very simple and easy approach, especially when you are planning for replacement. And the supinator crest bone can be reattached back using either anchor or mini screws. So always our concern is posterior interosseous nerve. So various studies are there, cadaveric studies, which says that the pronation actually increases the distance of the nerve from the approach, which can be in the Kaplan approach, it can be increased up to 5.6 centimeter in pronation, whereas in Cocker's approach, it can be up to 38 millimeter in pronation. And radial tuberosity is another landmark, which is intraoperative landmark. The PIN is at least 2.1 centimeter distal in pronation, but it can come close up to 7 mm in supination. So that's also a very critical landmark when we are exploring the radial head and neck area. In EDC split approach, it is also as equally safe during only in pronation. So the bottom line is that whenever we are using a lateral approach, the forearm has to be kept in pronation so that a more safe zone can be created. So coming to the radial head excision, it is still controversial and unresolved. It can only be reserved for the uncomplicated, isolated, displaced fractures of the radial head, which are not amenable to internal fixation. Uncomplicated and isolated, no collateral injuries, no other bone injuries, but the head is shattered enough that it cannot be fixed, then probably that is the only ideal candidate. Primary excision is now infrequent because high incidence of concomitant soft tissue injuries are there, and doing a primary excision can increase the instability. So a late excision is definitely better compared to a primary excision if planned for. A careful EUA is essential to evaluate other injuries. The approach can be any of the three, either EDC split, Boyd, or Cocker's if LUCL is ruptured. So it has been biomechanically shown that a radial head excision alters the load transfer. Though the outcomes are satisfactory in most of the cases, it is seen that the type 2 or partial split fractures have better prognosis compared to 3 and 4, but it's because of associated injuries. And asymptomatic increase in carrying angle has been noted, and increased degenerative changes in ulnohumeral joint has been noted in longer term follow-ups. The next group is fixation group, and for a long time it was believed not to work because people think that it doesn't prove successful in our hand, probably because of our poor anatomic understanding, poor implants available. But in the current literature, almost 90% or more than 90% cases, the results are satisfactory. The best prognosis in type 2, there are partial articular fractures, and with increased comminution and instability, the prognosis is poorer. But still, the long-term risk of arthritis is less compared to excision. And we must always keep a radial head replacement system in handy when you are planning for a fixation. The approaches can be EDC split from the lateral side or Writington approach. If the Cocker's approach can be used if LUCL is ruptured, because that can be repaired after the radial head is taken care of. So sometimes we have this slice or shear fractures of the anterior part of the radius, in which there is a cadaveric study says there 70 degree of circumference is there which is not articulating to the sigmoid fossa, and only screw fixation with even keeping the head proud can be done, and it will be giving no restriction of motion. If possible, the periosteal hinge should be left intact to preserve the vascularity, but that's not always the case. So many times we get comminuted fractures, 2 fragment, 3 fragment, and there is a neck fracture also, all are free. Then the fragments can be taken back to the back table. The whole head can be reconstructed, a plate can be fixed to it, and then it can be put into the neck, and the neck can be fixed. And the annular ligament usually is released just anterior to the equator, so that we are staying out from any vital structures. And after the fixation is done, the annular ligament should be repaired along with the radial collateral ligament. So usually the plate fixation have complications of non-union and stiffness or blockage of motion, sometimes leading to plate removal. The safe zones have been defined, either one by Smith and Hotchkiss, which depending upon the pronation and supination, the zone is identified. And the easier one is the technique of Caputo. That is, the safe zone is in relation to the Lister tubercle and radial styloid when the arm is in mid-prone position. And the plate can be placed just anterior to the mid-axial line with the forearm. in the neutral rotation. So that is the trick where we get this part doesn't come in articulation either in full pronation or full supination. The next improvement in fixation came with the concept of low profile axial fixation by Mori, where they've used two smaller screws or Herbert screws to fix the fragments, and then cross screw or bouquet technique, two screws usually to take hold in the neck without keeping it proud and compressing at the neck fracture. Later on, these two screws evolved into a tripod fixation of 3 screws to improve more stability, this fixation is more biologic, so there is less stiffness and rarely implant removal is required compared to the standard plate fixation techniques. Sometimes you can use a small mini plate just to stabilize the neck area instead of extending into the lower down the metaphysis or the radial tuberosity along with this fixation. So this is a partial articular injury from the Boyd's approach, fixed with first provisionally with K wires, then with screws, and then the bouquet fixation can be done along with that. The last group, the last mode of treatment is radial replacement, which is actually metal spacer arthroplasty as described by More. And this is only reserved for the type 3 fractures and associated injuries which are not amenable to fixation, where the fragments are impacted, deformed, or lost, or too small to be repaired. There is metaphyseal bone loss or more than 3 fragments, which is non-reconstructable. Then probably a replacement is a better option. The steps are very simple. Exposure, we resect at the neck at the desired level, intramedullary canal preparation, trial reduction, final implant, and closure. The size of the radial head, which we measure on the outside, they have 2 diameters, outer diameter and major diameter, which is the towards the articular side, and a minor diameter towards the neck side. So the minor diameter should correspond to the prosthesis size. So always use one size less than what we measure. It's better to get a press fit rather than using cement, but yes, sometimes we may have to use cement for stabilization. Modular prostheses are more popular compared to monoblock, but still monoblock is commonly in use in our subcontinent because modular ones are not available. Always we must repair back the lateral collateral ligament to the lateral epicondyle nicely with an anchor and locking stitch as in the picture to get a proper lateral stability. So the concept is to avoid overstopping during trial implantation, that the radial head should articulate at the level of proximal radioulnar joint, which is typically 2 millimeters distal to the tip of the coronoid. So tip of the coronoid can be visible just proximal to the prosthesis margin. And the congruency should be seen by pronation supination and flexion extension, both visually and fluoroscopically. Radiological parameters have been described, but they are not very reliable. The first described is the medial allohumeral joint space. It should be parallel. If you see the middle diagram, there are 1, 2 are the lateral joint space and 3, 4 are medial joint space. So 1 and 2 are not useful. 2, 3 and 4 should be equal. But it is also very crude because at least 6 millimeter of the radial need to protrude to change this. Another new concept is avoid understuffing. So how to avoid understuffing? That in neutral forearm, in extension and supination, there should be 2 millimeter prout of the radial head in the radiographs. It should not be down. So even understuffing is also a concern in some studies. So the usual outcome is good in medium terms, though radial head replacement has poor prognosis in late interventions. The complications can be neck fracture when we overzealously retract the radial neck out to rasp. We need to be more careful. PIN palsy when you put the homans just behind the neck to take the radial neck out. So we need to be very careful for that. Post-operatively stiffness, then this myositis ossificans, prosthesis failure or capitular osteolysis are known complications of radial head arthroplasty. However, this is a simple flow chart what we have discussed, that if the fracture is undisplaced, early motion is the treatment. If it is displaced and no block in motion, again conservative and early motion. If it is blocking the motion in supination, pronation, or causing crepitus and associated severe concomitant injury which require treatment, then we think of either excision, ORIF, or radial arthroplasty. For small unrepairable fragments, it should be excised. If it is repairable fragments, we should be fixed. For larger fragments, if ligaments are intact, an excision even can do. But if it is the ligaments are also not intact and the fragments are not fixable, probably a arthroplasty along with ligament repair or reconstruction can be the final solution. Thank you so much for the patient hearing.
Dhananjay sir, thank you. I know it was you have to debate among three things by yourself only. So you have crossed the time. So I'm sorry for that. Okay. So without taking any questions, so we'll shift. Sorry, Dhananjay sir. So we'll change this to the next speaker. Now I welcome our local hero, Dr. Samarth Mittal, who is also working at AIMS Trauma Center. Considering his place and working and interest, I've given him a topic of fracture dislocation elbow. Only caution to Samarth sir, थोड़ा समय का limit, थोड़ा सा जो topic हमारे लिए जरूरी हो हम के लिए वही वाला दिखाइएगा, right sir? Okay, so again now the desk is for Dr. Samarth. So please start, Samarth sir.
Good evening, sir. Thank you so much. I thank the DOA and especially Dr. Pushkar for giving me this opportunity. And before I start, I would like to thank my team, especially Professor Vivek Tikha and my team of senior residents, Dr. Dibyendu, Dr. Anupam, and the rest of the team who has helped me prepare this talk. Over the next few minutes, I would be talking to you about the fracture dislocation of elbow, and I would try to cover up the approach and fixation plan. I'm Dr. Samarth, like Dr. Pushkar has already introduced me. I'm an associate professor in Orthopaedic at Trauma Center AIMS. So over the next 12-13 minutes, I would try to cover up what's a fracture dislocation of the elbow. I would try to take up the different types of fracture dislocation of the elbow. I would briefly touch up upon the approaches because most of it has already been covered. I would then go on to the fixation options, and if there is time left, I would try to cover up some cases as well. So elbow joint, as we all know, is one of the most common joints to dislocate. In fact, it is only the second joint after the shoulder joint to have the most common dislocation. Without fracture, we have already discussed that it is typically stable after a closed reduction, and there is no doubt about it now after the first talk. And a lot of foundation has already been raised with the fixation of radial head fracture. So a lot of things will become easier for my talk. But whenever it comes to a dislocation of the elbow with a fracture, then it is a completely different ballgame. It is nothing as compared to the one without the fracture. So essentially the elbow dislocations associated with fractures are called the complex elbow dislocations, which is what I'm going to talk about today. So as most of us know that the elbow joint is made up of three major joints, which is the radioulnar, ulnohumeral, and the proximal radioulnar joint. But the one that defines dislocation of the elbow is only and only the ulnohumeral joint. We are not talking about the radioulnar joint or the proximal radioulnar joint. So when we look at the mechanism of injury, it has already been discussed in the first talk that we are talking about the circle of Araya, of how the injury happens on the lateral side first, and then how the capsule gets affected, and we go on to the medial side, and the medial sided structures, especially the MCL, is the last structure to get affected. So if we have a very severe injury, then we will start the injury from the lateral side, and then we go on to the medial side, going up to the MCL. Now, complex elbow dislocations are classified as per a lot of classification systems. One of the most basic and the foremost classification system used is the one given by Ring and Jupiter. The simplest fracture is the posterior dislocation of the elbow with a radial head fracture. Probably a lot of fractures that Dr. Dhananjay has already covered had a posterior dislocation to start off with and also had a radial head fracture, and they were reduced by the time they presented to us. The second most common type, which is a very famous fracture given the name of terrible triad, it has three components. One is the fracture of the radial head, the other is the fracture of the olecranon tip, and the third is the rupture elbow dislocation, but it also has a rupture of the lateral collateral ligament most of the time. The third different type of fracture is the anterior transolecranon fracture dislocation. So here the olecranon is fracture, and the important thing to note here is that all the structures distal to the elbow, that is the intact forearm, dislocates anterior to the joint, not posterior to the joint. And this is where it mainly gets differentiated from the proximal Monteggia posterior fracture dislocations where the dislocation is mainly posterior. The only other difference being in the transolecnon fracture dislocation, the proximal radioulnar joint is not affected at all. So that is not dislocated like a Montegia fracture dislocation. Whereas in an elbow dislocation with Montegia fracture type, any part of the olecranon may be affected. It is not just the diaphyseal ulna, it may be the olecranon part of ulna, but the proximal radioulnar joint is also affected. And when the ulna is very comminuted, then it is very difficult to differentiate between the two types at all. So these are the 4 types of main complex elbow dislocations. There is another classification system which talks about almost the same types: radial fracture with unknown dislocation. We've talked about this, terrible triad we've talked about. The only difference variety that they talk about is the varus posteromedial rotatory instability. Here there is a LCL tear on the lateral side and a coronoid fracture, which is a sublime tubercle fracture, which is mostly on the anteromedial aspect. Radial head fractures are very rare in these injuries. The coronoid fracture is definitely present, and it is a medial facet fracture, which often requires plating from the medial side, which we cannot operate through only a lateral approach, which is commonly done for most of the radial head fractures or a LCL injury with a coronoid injury. And the other fractures are olecranon fracture dislocation, that is covered by the earlier classification system. Another type is a lateral column fracture of the distal humerus, which may have a dislocation of the elbow. That is another column added here. So how to approach, like it has already been discussed for the radial head fractures, same approach, posterior midline approach, whether you put the position lateral or you put the position prone or you put the patient supine with arm over the chest. This is also a position that many surgeons like to take these days. And it is the usual approach for anterior transolecnon fracture dislocation or a proximal Montegia fracture dislocation. Essentially fractures which already have a olecranon fracture to start off with, because for these fractures we have to go posterior. Vis-a-vis a lateral approach plus minus medial approach, which are usually used for a dislocation with radial head fractures that Dr. Dhananjay has already talked to us about, or with an LCL injury, or terrible triad injuries where a radial head as well as the coronoid fracture can be fixed through the SOM approach, or a varus posteromedial rotatory instability, which may require dual approach, or a lateral column fracture of the distal humerus, which can be approached through a posterior approach as well as the lateral approach here. So what is the fixation sequence? There is nothing fixed. As per literature, you can go as per your own reference, but usually many surgeons try to follow a sequence. There is no randomized literature, randomized trial which says one is better over the other. So most surgeons try to go to the coronoid fossa first, try to repair the coronoid wherever it is required. Obviously, if it is big enough and has anterior dislocation, only then it is required. So some surgeons say more than 10% of coronoid needs restoration, whether by a lasso technique or by a suture screw. That I will come later. Then we look at the radial head fracture. If it is reconstructible, like Dr. Dhananjay said, then it needs fixation. If it is non-reconstructible, it needs replacement. But like Dr. Dhananjay said, excision is not an option here because the elbow was dislocated to start off with. There is some ligamentous injury for sure. Radial head fracture, excision is not an option. Then we go on to the lateral tissues like the lateral collateral ligament repair. Then we go on to the medial tissues. If required, MCL can be repaired. And if still the elbow is unstable, then we may need to put in an external fixator. And if we have a olecranon fracture to start off with, then yes, sometimes we need to go to the olecranon first by the posterior approach to get the length and the rotation right. And we may need to use a fixator for this purpose when the olecranon is very, very comminuted. Coming to the coronoid, how do we fix it? Type 1 and type 2 fractures are effectively fixed with a suture lasso technique, whether by a lateral approach or by a medial approach with 1 tunnel or 2 tunnel, depends on the surgeon. But most of the type 3 fractures are fixed by screws. The only difference here being most of orthopedics, we go from the small fragment to the large fragment for more stability. So A to P screw means more stability ideally, but it has been found that P to A, so posterior to anterior screw gives better stability for these fractures. But if you have a smaller fragment or if you have very osteoporotic bone, then you may want to buttress these fractures, especially the posterolateral instability fractures where we have a sublime tubercle fracture which need buttressing on the anteromedial side. And most of the literature says do not attempt to lag screw fixation, especially in osteoporotic bone, because this will break up the coronoid. In case that happens, then the only technique left is to a suture lasso technique, pull it back on the posterior aspect of the olecranon and then tie it up there, either with a single tunnel or a double tunnel. Coming to the radial head, this has already been covered. The only thing I will add upon is there is no established literature or very convincing literature of showing that monoblock is better than modular, or monopolar is better than bipolar, or cemented is better than uncemented. There is no such thing. But many authors agree now that whatever type of replacement you may put in, if it is tight, it causes proximal radial lysis in the long term. And to avoid that, many surgeons have started using a loose fitting processes. They use it like a spacer essentially, and they have found better results with these. Avoid under overstuffing at any cost. Use a smaller size whenever in doubt. And excision is not an option at this stage. I am repeating that excision is not an option in a case of radial head fracture with an elbow dislocation. So coming to the LCL, it is usually torn at the lateral epicondyle. And you will see the characteristic bare area. So in most of the cases, more than 90% of the cases, if the LCL is torn, it is torn at the lateral epicondyle. And you will see a completely bare lateral epicondyle, which becomes very easy for a suture anchor or a bone drill or a tunnel system, depending on the cost, depending upon the surgeon preference. If you want to save on money and don't want to use a suture anchor, just drill a tunnel and repair it. Else a suture anchor comes in really handy. Out of all the three components, the LUCL is the most important varus stabilizer of the elbow. Lateral column, coming to the fifth type of fracture dislocation, is the lateral column fractures, where has a distal humerus fracture. This may just be a lateral column fracture or have capitulum or trochlea fractures as well, and they can very well be approached through the lateral approach. And small fragments can be fixed with headless screws. Large fragments require some plate. If you do not have an anatomical plate, then you can contour recon plate, like I've done in one of these cases that I did. Last structure to come in the circle of our eye is the MCL. The plate should be inserted. Plate over the distal insertion of the sublime tubercle is done if the coronoid is fractured at that level. Otherwise, MCL can be torn either at the medial epicondyle or at the humeral ulnar attachment or in the mid substance. It can be torn anywhere. We need to see where it is torn and we need to repair it there. Coming to the olecranon, it needs anatomical plates. Also keep a backup of very small hand plates or CMF plates, because sometimes you will see a lot of comminution, and this small comminution of the attachment of the medial collateral ligaments will need small plates. So coming to a few cases now, I have 3 minutes left. So this is a 20-year-old male having history of radial head fracture with a LCL injury. So we went in, the radial head fragment was really small. It did not require anything to be done. The only thing required to be done was a LCL reconstruction, and that was done. This is the clinical photo of how the repair was done. And this is the patient. You can see the small radial head fracture still present, but it is not causing any block in movement. And the patient went on to have good results. This is only the movement at 6 weeks. Another patient, a 20-year-old male patient having a terrible triad injury. It is difficult to appreciate the coronoid fracture, but one can really appreciate the radial head fracture here. And this is where I did I took the coronoid, pulled the suture, passed a tunnel, but before you tighten the tunnel, repair the radial head, because otherwise the space becomes too short. I repaired, and you can see how the elbow is still subluxing. And once I have repaired the coronoid, then it becomes stable. You can see with the small arrow that the coronoid fracture is still there. And still this elbow was subluxing. So I went on to the medial side, which had ecchymosis, and saw that the MCL was also damaged. And then I have done a repair of the MCL. See how the joint space is opening. And after the repair of the MCL, it is closed. This is a post-operative X-ray. This is the 1-month follow-up of the same patient. Another patient with terrible trial injury with a LCL injury. Here the fracture is in dislocation, but normally we should not have fractures, these X-rays, because these elbows should be reduced as soon as possible. And this X-ray is very clear intraoperatively that there is a coronoid fracture and a radial head fracture. Lateral approach was used. I tend to prefer the 3 tripod screw technique, and which is what I have done for the radial head. But before that, I put in suture lasso technique, put in a tunnel. If you see very closely, you will see the tunnel. And that is how it was repaired with the LCL and the radial head, patient having a good outcome, functional outcome. Another case of a 60-year-old patient with a olecranon fracture dislocation with radial head fracture, went posterior approach, radial head replacement, anatomical reduction of the ulna, and fixation, immediate post-operative X-ray, 3-month follow-up. Another patient with a transolecranon fracture dislocation, again went in with the posterior approach because the coronoid fragments were really small. I've just managed to fix them with 2 K wires and then fixed it with a plate. And this is 3-month follow-up of the same patient. Another 50-year-old patient with a Montigia type of fracture dislocation, looks pretty bad, but keep the small plates in hand. I have used 2 plates for the ulna here and fixed up the lateral collateral ligament with 2 screws. Another patient with 60, I will just skip this case and go on to this case where I have done a posterior approach Everything was fractured. I fixed the small fragment with HCS. I have put in a posterior plate. I fixed the olecranon. This is a transolecranon dislocation. However, the results are always not so good. The images look very good clinically, but in the follow-up, the olecranon just came off. And then this patient had to be revised and did not have such a good outcome. This is a 29-year-old male having a dislocation. You see the MCL is definitely torn. The lateral side structures are fractured. And this is the lateral epicondyle fracture. I went with the lateral approach, posterior plate, fixed the capitulum and trochlea with some headless screws. Still the elbow is dislocating. Repair. This is how it came out on the lateral aspect because the LCL was avulsed. I put the LCL back in, repaired it, but you see that the medial aspect is still accommodations because the MCL is ruptured there. The patient the skin was not looking healthy, and I operated this after a week and put in a medial suture anchor, repaired the MCL, and this is how the patient looked in the post-operative follow-up at 1 year, and this is the outcome. I thank you for a patient here.
Thank you so much. Thank you very much. You were really fast.
Sir, I think I finished in time though.
Abdi was really fast today. Okay, so we'll start with case because we are behind the schedule for 15 minutes only. So Harpreet, can you start the case? And by the time you get ready, Samarth, simple terms, 2 sentences answer. How a simple fracture dislocation case, what to see in the X-ray or in the CT scan to see my approach entering into the elbow joint. What I should see in the X-ray and CT scan or MRI to plan my approach for a simple orthopedic surgeon.
Sir, I keep it really simple. Thank you for that question. So if I have a olecranon fracture, no matter it is a Monteggia fracture dislocation or a transolecranon fracture dislocation, it means I have to go posterior. My answer is clear. Even if the radial head is fracture, I would go through the Boyd interval and do a radial head replacement or a repair. So if there is a olecranon fracture, my approach is fixed. I go a posterior. If I have only a lateral sided structure or a coronoid fracture with a radial head fracture, then I go only lateral. And then I see for the MCL at the end of it. If it is torn, I go for a dual approach. And if I have a LCL repair, LCL injury with a sublime tubercle fracture, I have to go both ways. I have to go medial and lateral. However, if there is any doubt, I will go posterior because with the posterior approach, I can do almost everything at all. Okay. Whenever in doubt, go posterior.
Okay. So Dhananjay sir, so is that we enter through the zone of injury? So where the maximum number of injuries are, so we're entering through those area only. If it's on the lateral side, so we go on the lateral side. If it's on the posterior side, so we'll go on the posterior side. Is that right, Dhananjay sir?
Agree. Completely agree.
Sir, mute ho gaya aap.
Completely agree.
Harpreet, yes.
Thank you, sir. Dr. Samarjeet is there. Sir, hai? So maybe sir will join in between. So I think let's unmute everyone and let it be more of interaction. I cannot, the esteemed faculty has already taught us. So it will be just be a revision of what already has been taught by Dr. Deepak, Dhananjay and Dr. Samarth. I would not be talking or presenting anything new. So we have Dr. Samarjeet also. Can we start with the first case?
Yes.
So everybody on mute. Its questions are to everyone. So 31-year-old male, history of road traffic accident, presented to the casualty with this picture, non-dominant upper limb, neurovascular intact. He's a aircraft technician, so lifts things, heavy work he has to do. So this is the emergency picture. My resident sends me this picture. Now what do I tell him? It's clear. We have to take him in GA, or we can do in the casualty also. Dr. Deepak, any indication of always giving GA, or?
Actually, depends on the time. If we can do under conscious sedation,
yes.
It is better if we have a relocated elbow. So we can always try, because probably this is going to be unstable. Even if we go in for GA, I'm not sure whether we will end up with the stable elbow. Maybe even in the slab, it will redislocate. So first I will try.
How do we reduce it? We reduce it under local, under block, under sedation, or under GA?
under conscious sedation in the emergency, we can try. And if you have a good anesthesia team, they can give some kind of block there in the anesthesia, there in the casualty. It can be a plus point. And I would rather try to do go without not to do general anesthesia in this case, because this would have a high probability of pre-dislocation.
Okay. Okay. And so first, a disclaimer. So most of these cases are which we have done with our trauma team in spinal injury center. So with thank you to Dr. Pushkar and Dr. Atul, with whom we have done all these cases. Dr. Samarjeet sir, so we reduce it usually in the emergency only. Usually give a hematoma or a joint block, and we can go ahead and reduce.
Samarjeet sir, how do you reduce? Just pull it.
So actually, from a peripheral practitioner point of view, see, reduction, even normally an elbow dislocation would reduce with minimal effort. So just reduce it. Maybe patient has a little bit of pain, it should be reducible there. And because we take an anesthesia and then it redislocates again, patient is already very shaky on that. We know that it is not going to stay. So reduce it, keep little more flexion, check that neurovascular is intact, and then plan accordingly. Whatever the next thing we are planning, a CT or maybe whatever surgical intervention we are planning.
Okay.
But from a peripheral practitioner point of view, first reduction with minimal sedation or hematoma block or something to reduce the pain and reduce it. And elbow, my boss used to say that elbow dislocation is you catch out of the patient's hand and he'll say, will it be painful? He will say, yes, it is. And he'll pull it back and it will come up. That is what my teacher, when I was MBBS student, he used to say. Elbow dislocation is one, you catch his hand firmly and tell him, bahut dard hone wali hai. And he'll try to pull it back and it should come. That is what a general thing is to say. No, that it is not always true. So that is what I meant to say. Just reduce by whatever means, and then we go to the next stage.
So next plan of action, reduced. This was the image. So any role of further imaging in these cases? I think we didn't discuss about further imaging. Do we get CT, MRI, both? 3D CT? We can have comments from our DOA faculty also. If anybody wants to pitch in, or Samarth, you can come.
I think all these injuries require at least a CT scan. And in my opinion, in the acute stage, there is no role of an MRI. So all these patients in my setup will get a CT scan. And going back to the previous question, I think I am the outlier, being the one in large volume government hospital. And these patients will get reduced in the emergency in no time. So it takes a few seconds, and without any anesthesia or any block, these would be reduced. And the patients, in fact, will thank you for reducing them, because they come with a lot of pain, and the moment you reduce them, the pain is absolutely gone. So only after reduction, a CT and no MRI for me.
Samarth, you are not an outlier. I think you are in the majority. We reduce them in the casualty, most of these. So CT for all, 3D CT. Yes, Dhananjay, you want to come in?
I see a shadow behind, small bony chunk, bony shadow behind. I know laterals are gone. For that I don't need an MRI. But when I see a small shadow somewhere here,
which side? Lateral view?
Just above the olecranon on the lateral view, a centimeter above the olecranon.
This shadow?
No, not the anterior, posterior.
AP view.
Posterior.
Okay.
So
AP view.
Lateral view, posterior, 1 centimeter above olecranon tip.
Somewhere here.
I think that's the plaster.
No, that's the plaster shadow probably.
Okay. So I think we all agree that we should go ahead and get a CT scan.
Shadow in this case, but if we see a small chunk there, that is something can be a triceps avulsion.
Okay. Yes.
So that can click your mind. There must be some.
Okay. This one you are saying. Yes. So triceps avulsion is also common in these. Can be there in these. Not common, but associated. Has been associated with these patients.
We always take care of the lateral, medial, and anterior, but we rarely think about the posterior soft tissue. And many times they have a triceps avulsion.
So triceps is known as a dynamic stabilizer of elbow, and we should look for. So I think consensus is that CT scan is of help. We always X-rays. We underestimate the amount of injury.
Yes.
So CT preferably the axial sections at least, and if we can get a 3D reconstruction, there's no harm.
Yeah, I
Dr.
would like
Samarjeet,
to
anything
add
else?
that
Yeah,
I'd like to add that usually the 3D reconstruction, especially here we are dealing with small fragments, it doesn't usually add much to the knowledge. It adds to the cost, but probably doesn't add much to the
So at least the axial
knowledge.
sections we should get.
Yeah,
that's simple. Okay. Okay, so we move ahead. We did found that the elbow was dislocating or subluxating at about 45 degrees of flexion. So this was the CT scan.
Can I make a point there?
Yes.
So we don't have a doubt that this is a terrible triad injury, and this is a 31-year-old young male. So there is no point of a conservative management. So we shouldn't be checking for the stability of 45 degrees. That is pointless.
Yeah, point well taken. So CT scan, we see this injury. Does it add to anything to our information, which we already know on the X-rays?
So like Dr. Dhananjay said, 3D CTs are not useful in these fractures because the fracture fragments can be really small. So here the role of 2D CT is more than the 3D CT, unlike a scapula fracture. And sometimes we tend to see only a 3D CT and tend to miss out on the small avulsions, and hence only a 2D CT should be looked at. Only once you have looked at it in detail, then you should check on the 3D CT. Showing primarily a 3D CT is ideally not the right thing to do.
Okay. So there was a radial head fracture. I think there were some fragments around the lateral collaterals and coronoid, which we could see in the CT scan. So plan, approach, what to fix, how to fix. I think all this has been discussed. Samarth, can you just go ahead and just help us revise this? How would you go? What would be your approach to this?
So if I've seen the 2D CT and I know it is just a terrible triad injury with a coronoid fracture and a radial head fracture, I would go with the lateral approach. Cocker's approach is what I prefer in these patients, but like it has been discussed, Kaplan, Cocker, anything, because the moment you give the incision, the plane is already made, you just go in. And first thing I would do is take the radial head slightly down and look at the coronoid first, because once I repair the radial head, it becomes difficult to look at the coronoid. If the coronoid fragment is small, then I would just take a suture lasso and
so we have a coronoid. You have an image of a coronoid fracture. Do you think you'll be able to?
Yeah. So this fragment looks big enough. I can put in a A to P screw very easily in this fragment. So I would probably take a suture lasso and then put a anterior to posterior screw in this, fix the coronoid, and then go on to the radial head, fix the radial head, and then repair the LCL and come out.
Samarth, in your experience, how easy is to do a screw fixation from the lateral side for a coronoid fracture?
So it depends on the type of fracture. If it is a MUCL avulsion, then the coronoid fracture goes from the medial side. But in this terrible triad injury, after you take a bite into the coronoid, the soft tissues, and you pull it down, then you have a complete view of the bony fragment. Don't hold on to the bony fragment and pull it down. Put a suture, pull it down, drill the tunnel. Once it comes in place, then just take a K-wire and then put it. Sometimes the view can be small. In that case, only a suture lasso should be good enough.
Okay. Dr. Pushkar, Dr. Samarjeet, do you want to come in, or shall I go ahead?
I'll just say whichever the way you want to fix, whichever the way you are comfortable with, maybe with a lasso or with a screw. If you can go, if you have experience of Dr. Samarth, you can fix it with a screw. If you have inexperience like us, I will say just suture anchor or your lasso should good enough. You just need to hold the anterior capsule and the coronoid there in the place, whichever the way you want. Maybe with the ethibond or with your fiber wire, if it's preferable, whichever the way you want, you can fix. Samarjeet sir, anything special?
No, I think, no, very well said. Idea is to basically obliterate the anterior space for the tissues to come out. So you need to get the anterior capsule back onto the ulna and that reduce that space. Whichever way you can. If you have a major chunk and you are comfortable enough to fix it. Even if you don't fix it, basically point is to basically get the anterior capsule back on space. So that is more important. Otherwise, there will be space for the tissues to move in again and cause dislocation.
Dhananjay sir.
Yeah, even I find this mini first pass is a very nice instrument to take a bite. apart from the lasso.
It's an arthroscopy instrument.
Arthroscopy instrument, mini first pass, which you use for this root repairs. That's a very nice instrument to be used in such small space with a lot of safety compared to a lasso.
From Samarjeet sir, I've used, learned one thing, the Rajai.
So it's basically you need something which has a hole and can go in. I have a long straight needle. The people use Rajai ko repair karne ke liye lambi needle hoti hai. It's a sturdy, thick needle, and it's got a wonderful big hole in it. And I always keep it, and it's dirt cheap. I keep 2-3 needles always on my table.
Right.
I am doing tricep avulsion. I am doing triceps this thing for this thing tendo Achilles, even for elbow. Just make a drill hole, get that needle in, pass in a suture, and get that out.
Sir, this is just first case. We have to finish 2-3 at least.
So,
even the fragment can be reduced a bit. If the fragment is too big, that will give a better cosmetic appearance on the X-ray.
So,
if you have the luxury like Dhananjay has, then definitely
and take it off a bit.
So we use the lateral approach, as we said. We use the Kaplan, or we use usually the EDC approach, split approach. We always we fix from inside out. We usually go to the coronoid, then the radial head. Then we tried to fix the coronoid with pull-out screws. We couldn't get the good reduction of the coronoid. We fixed the radial head and we pulled it down. We have already tied it in this X-ray, which you see here. We already tied it with pull-out screws, but we couldn't get a reduction, proper reduction. I don't know if that was very important or not. We fixed it with screws. Regarding the approach, I think when we open up on the lateral side, there's already an injury in the fascia, and we just go through the plane. We don't need to usually define the interval. You just go through the injury plane and we can go up to the injury. So we fixed the lateral side. You see the suture anchor fixing the lateral ligament. Then we went fix the radial head lateral, and then we used the medial approach. Again, which medial approach do we use? The FCU, the Hotchkiss, or the Taylor sham? Anything from Samarth or Dhananjay? Which is the medial approach? Or Samarjeet sir, or Pushkar sir? Which medial approach do you use? We use the FCU approach, where we go through the plane of the ulnar nerve and go to the coronoid and fix it. We use the hand plate here and to fix the coronoid. So anything different would you have done, Samarth?
Sir, this looks perfect, sir. This looks very good.
Any approach we use differently?
Yes. Sometimes if I have an isolated coronoid fracture, I go direct anterior, because I work with a lot of vascular surgeons and I'm quite comfortable with that approach. If I have only coronoid fracture and dislocating an extension without radial head fracture, I go direct anterior.
Dhananjay sir?
Dhananjay also is quite of has an interior approach, quite favorite.
Not for the coronoid, I'm yet to start. But yes, for almost all coronoids I fixed is through the FCU split.
Okay, FCU.
So this is 18 months follow-up. So he's back to his work, good range of motion. He's able to lift heavy weights also, but patient is still not happy. Patient says that there's the extension is not full. So one thing we can't, you have to talk to the patient and try to get his expectations match your result.
Okay.
So any comments, or we can move on to next case.
Next case, Harry.
Okay, recently operated 57-year-old female lady, history of slip in the bathroom, came from in US. Came from US with a slab, non-dominant arm, neurovascular intact. She came with this. I think she didn't come with a reduced. She came with the dislocated elbow like this. So next, so we did a reduction in the casualty, and this was the picture. Again, lots of fragments here, radial head fracture, so fracture dislocation, and CT. No 3D CT this time, Samarth. Any different plans or the same?
So probably we are dealing with the more comminuted radial head fracture here.
Yes, Deepak sir. Yes.
Yeah, so the coronoid fracture is also there. Again, an unstable injury. So we should be more prepared for a radial head replacement here. We may not be able to fully reconstruct the radial head.
Okay. Sir, Dhananjay, are you anytime worried, or do you look at the patient's age when you're thinking of doing a radial head prosthesis? Does age matter to you, or is there a number below which you would not do a prosthesis?
Not exactly. I am yet to do a ORIF in elderly. Most of these injuries are younger patients only. That's only when I see literature, I find that there are some comparative studies published, 1 or 2 studies only. And the outcome is not much different, but it is better in a replacement group, definitely, when the age is above 70. But
so does, if there is a young patient with a comminuted radial head, would you not do, or would you have any hesitation doing a radial head prosthesis?
No, I do not have any hesitation. I am pro putting a prosthesis rather than wasting and struggling on a comminuted radial head to fix it.
Any difference of opinion from the faculty?
Samarjeet sir, regarding the radial head processes, anything in the mind that it works, it's a metal or something?
No, actually, we have to be prepared. If you are dealing with an elbow, fracture dissolution elbow, and it's an unstable one, then we know it has to be in the back of the table. Only problem I find doing radial head replacement is the processes which we get, they have a very thick and long stem, and it tends to just hit one of the cortices on the radial head, and we really have to struggle getting it down to the level we want. So I sometimes get the processes which are a little shorter stem. I've got it cut and have it on the table, because it's basically a spacer block. It is not to be very firm holding and not to be cemented and things like that. The earlier processes when I was having a problem just sinking it in. And now when I get it, now I've told the implant guys, give me some of the heads which have a radial head which has a short stem. Even those bipolar ones, they have a long head. You really need to cut in very deep in. So I don't even prefer a bipolar radial head spacer block there. It's because it's basically a spacer and has to be a little more synced in than more proud. If it is more proud, we'll lose the movements there. So that's the only thing I have done now over the time.
Samarth wants to pitch in.
Yeah, so I face the same problem. So what I've started doing recently is, if the LCL is not already ruptured, I do a osteotomy of the lateral epicondyle, or I just take off the LCL and then fix it back with a suture anchor, and then things become slightly easier. Obviously, the problem still remains. And the first question, that only thing different I would look at in this patient is, I think this patient has a higher tendency of a MCL tear based on the first X-ray that we saw. So I would keep, rather than 1, 2 suture anchors ready. The second X-ray. Yeah. The second one. Yeah. Even on this one, you see the lot of valgus is there. So that is indirect indication of a MCL tear. Obviously, if there is ecchymosis on the medial side, it is even better indication.
Samarth, I think we're still evolving on whether the most common, which is the most common, more important theory, the Hori cycle or the valgus extension, hyperextension theory, which is the more commoner injury. So if you go by MRIs, and some studies still say that the MCL is the most common injury. And they, as Dr. Deepak also said, they said that they go, when you are repairing these structures, you go climb up the ladder. Yeah. So you go from the last injured structure, which is the LCL, and then go up to the MCL. MCL would be the last structure you would repair. Yeah, and also in most of our daily activities, it is the LCL which is coming under stress, except for throwing athletes, in which MCL is coming under stress. Daily activities, it is the LCL. So always repair has to be on the lateral side, except if there is an MCL aversion. Okay, so can we move ahead? Injury.
So I just like to add, I'd like to add a couple of points regarding radial head arthroplasty. I think
Yes,
Dr. Samarjeet actually pointed out the problems in India, especially if we have an older female and with small bones, the stub of the implant that actually creates a problem. It is difficult to get in, and there is often a breakage in the cortices, the radial neck cortex. And I usually keep a small cerclage wire ready. Sometimes I faced a problem. I put the cerclage wire before inserting the prosthesis, and sometimes just because of that thick stub, we have to downsize the prosthesis so that we can get prosthesis inside without any problem. Another option which is there, especially in peripheral centers, if the radial head is not available, if cost is an issue, then sometimes we can reconstruct the head and just put it there as the head as a spacer itself, and prognosticate the patient that this may need removal later on once the soft tissues have stabilized. So this is another option.
Yeah, that's a valid and good tip for the general practitioner. Suppose we have not ordered for the arthroplasty set for the elbow. So there's the system you can put your bone there just to give him a space, just to get the length on the lateral side. But you have to counsel your patient beforehand that whatever you are doing is not right, maybe needs to be removed at a later date. And supination pronation may get restricted because of this. So that's we can take it out later. Let's first get the flexion extension range. Yes, Samarth wants to add on.
So just the medial ecchymosis that I was talking about, I see it on the clinical picture here. So
what you can't be wrong today.
but medial side ecchymosis comes because the patient keeps the arms like this, and all the bloods settle down from the medial side. If you see your majority of the elbows, they have medial side ecchymosis. But
MCL injury is commoner, sir.
Is commoner, but you don't repair for this.
Yes. Not all need reconstruction.
Yeah. These are indirect signs. So in the intraoperative varus valgus stress should be checked first.
That's to be checked. So this is a good point. Yes. Chalo, sir. Jaldi, sir.
This was the posteromedial ecchymosis. This was a flexion block. We opened, there was a rent here in the fascia only, and through this rent we can approach. The radial head was found comminuted, and even the coronoid was found there. So again, as Dhananjay, as Samarth, as Dr. Samarjeet said, the size we undersized. We found it was about 22 mm. We undersized it. We couldn't reconstruct because it was comminuted. We did a radial head arthroplasty. So just Dr. Pushkar is a very brave surgeon, so he's using a finger instead of putting a Homans there. So just a pull out sutures for your coronoid. And the issue Dr. Samarjeet said we face when we are reaming for your radial head replacement. So it's very tight. Whatever number of radial heads we have done, we haven't done any cemented. We have just put in as a spacer. We haven't found any space to put in cement. We have done just loose, uncemented radial head prosthesis. Just some videos. How can we move ahead? So we did prosthesis, reconstructed the ligament. We have already pulled out the coronoid using lasso sutures. As Samarth said, it's important to look for the medial stability here. So stress testing was done, and we found that it was opening up. It's looking at the ulnohumeral joint. Medial ulnohumeral joint was opening up, and we had to do a reconstruction or a repair using suture anchor on that side also. And this was just 2 weeks. This is just her movements at 2 weeks. So we can mobilize. I think this is a way of reconstruction has given us a predictable way of getting the results. I know maybe 18 years back, 16 years back, when we were Dr. Deepak, me, Dhananjay were in MAMC, I think we were treating all of these maybe in plaster conservatively or radial head reconstruction, radial head excisions. But that was, I think, not a predictable way of getting them full function. Though a lot of them, not lot, some of them did get good function, but this is a more predictable way where we can give them good early function. Dhananjay, you want to comment?
This difficulty to ream the radial metaphysis for prosthesis from the lateral approach is probably when I go through the this Writington's approach and its propagators, they found it's very simple. When you osteotomize that part and reflect the annular ligament, the radius simply comes behind sublux posteriorly and easy to go. I'm yet to try, but I will definitely give a try next time.
Sir, is that tightness is because of our small canal or because we are not able to make it lateralized?
It's not. I think we struggled because of the canal size.
Inside the annular ligament, the radial
it
doesn't come completely out, so it keeps on struggling.
Annular ligament is already torn here because the radial head is torn.
To the time it is torn, if it is not torn, we always incise it to submerge the radial metaphysis, and when we start reaming, and or we start opening the canal, but it's always a struggle. It's not a simple way. You keep on breaking sometimes the cortex, as we have discussed.
Samarth, sorry Harpreet, sorry everybody. Samarth, last comment, and then we go and take it out. Pearls from Kotwal, sir.
Sir, I think the advantage in this case is MCL is torn. So whenever the MCL and MCL both are torn, it becomes really easy to put the radial head in. When the MCL is not torn, the whole of distal humerus, proximal forearm doesn't come laterally. And then there is a bigger challenge. So I think MCL, whenever it is torn, it becomes easy. And whenever we are doing the posterior approach through the Boyd approach, it is easier. So with the lateral approach, it is always tricky.
It's 9:30 now. So we will ask Ravi sir, can we proceed or we have to stop in 5 or 7 minutes now? Because we need additional 5 to 7 minutes from
Kotwal, sir. We can go through for 10 to 15 minutes. No issue.
Okay, so last one case, Harpreet.
Okay, sir.
Not more than this.
Bilkul, sir.
But faster.
Faster. 33-year-old male, fall from bike, left arm, non-dominant shopkeeper. This was the injury. So I haven't brought simple dislocations. Sorry, Dr. Deepak, and any simple isolated radial head fracture.
I actually had a couple of cases, but my computer is very slow. I don't think it will come up very easily. Okay,
so,
please go
radial
on.
Head, radial head fracture. There was no history of any dislocation, or we didn't get any X-ray. So this was the picture. Drop picture. Ecchymosis, sir. Dr. Samarth, medial side ecchymosis again. So we went through the lateral approach, as we said, as Dr. I think Dhananjay and Dr. Samarth also said, we always find a bare area here. It's usually the ligament along with your your extensor mass. It has all come off. There's nothing over there. And we could see, I'm not sure if we could find, we could see a bare, we could see the coronoid also bare inside. So there was no, X-ray didn't tell us any coronoid, wasn't suggestive of any coronoid fracture. There was no fracture seen, but we could see a bare coronoid inside from this lateral side. So I think, sorry, can I go back? Yes, I'm sorry, my computer is too fast for me. Here, I'm not sure which image could show that. And on the X-ray in-top imaging also, the joint was dislocating. Posterior.
Bottom two images, I think, yeah, it is dislocating.
So that was dislocating posteriorly. It was subluxating posteriorly. So we did this. This image also shows.
Harry, just a minute. Samarth sir and Dhananjay sir, a picture back, Harry. Harry, there is also a Hill-Sachs sign. You have similarly in the shoulder. This posterior, the picture on the right side and lower side. There's a cut on the coronoid. So this is a sign something that it will dislocate again, as we have in a Hill-Sachs lesion in the shoulder or something. that this my radial head is impacted posterior laterally and it has come out then. If there is something signifies or it just assumption of mine?
Should I answer, sir?
Actually.
हाँ समर्थ बताओ.
Sir, I think this is मतलब मुझे तो ये लगता है this is a sign that the radial head had dislocated once at least and it has damaged that structure at the back. Whether it is like a Hill Sachs will मतलब it decreases the stability, that I don't know.
Okay.
It's like a shear fracture. It's a shear fracture posterior to the capitulum. Either the radius, the radial head anterior part is sheared off, or sometimes it shears off the posterior part of the capitulum. So this is a shear fracture. That's a sign the radial head has gone out and come in.
Okay. Right. Yes.
So
yes,
this X-ray showed that this was subluxating posteriorly. So there was no coronoid fracture, but there was just a capsular avulsion. And we, even after doing a radial head prosthesis and reconstruction, it was still posteriorly. We have pulled out the sutures from the capsule. We haven't tied them. And as soon as we tighten them, we have a good reduction. So this was one case. I'm not sure whether this is common. Pure capsular avulsion of the anterior capsule. We usually find, and there's a small chip fracture of the coronoid, but here it was a pure capsular avulsion, and which was still make it unstable. So any comments? These are some intra pictures, and this was at the end. And this is 6 weeks follow-up.
Can I chip in here?
Sir.
Case, difficult one. I would like to say this is one case where CT is important. Because what we are presuming or assuming whether there is a fracture from the coronoid or this thing or that thing, that would become clear, number one. Number two, the X-ray shows as if there are two large fragments from the head of the radius. I mean, not as comminuted as we had seen in the earlier X-rays. So that the CT will also make it clear as to what can be done for the radial head, particularly because this is a young patient, about 33 or something, I think, right? So if this is two large fragments, maybe a little small comminuted something which actually can be excised, but if you can reconstruct the major part of the head of the radius, then perhaps it can also be reconstructed rather than putting in a prosthesis. Of course, that's also a correct decision, because if there is comminution and all this thing, but all this thing information you will get beforehand if you do a CT scan. But well, it's a well done case anyway.
Sir, just want to know, sir, because there was no history of dislocation here. The patient has said it was not dislocation. Nobody has reduced it, and this is the only fracture. And where he has gone earlier, they have said that they are going to fix it or replace it or throw it away the radial head, and they are not. And my elbow will become stable. Is in that case, may I become more wiser in going through an MRI and check it out? Is there was a dislocation, because the radial head looks the fracture and grossly displaced. So there has to be an injury which has done this displacement also. While that injury is that time I will become a little wiser going through an MRI and knowing that there is a some other ligamentous injuries also, so that I can prepare beforehand, like getting my laser things.
Like what Samarth said in his lecture, the CT is more important here than the MRI in the acute setting, because CT will give you about, as I said just now, about the bony fragments, and after you have fixed them, or if you have fixed the radial head or whatever, then you can assess about the ligament injury, which actually most of the speakers have done and shown cases where they have gone in from both sides, medial as well as lateral, to repair or reconstruct the ligaments.
Right.
Point was basically just to reiterate what Dhananjay had said, that isolated fractures of radial head are less common. Concomitant injuries with radial head fractures are very common, and we should look for them. Samarjeet sir, some words from you, and then
just want to add one thing. Whenever, even if a very narcos looking radial head we are doing, whatever we are planning to do, do give a varus valgus stress test, try to dislocate so that you can delineate your injuries operatively before, if whatever, sometimes in the periphery, the trend is to just throw away the radial head and go and do a radial head excision and call it a day. So whatever the thing one is planning has to assess the elbow stability before taking a decision to throw the radial head out ever. Or else in a periphery, if somebody is wanting to even exercise, maybe delay it a little for 10-15 days so that basic elbow stability is there. And then if he is planning to do a excision, that's the only thing I can say, that if somebody is even planning for a excision sort of a thing, do be very sure that we are not dealing with a situation where it's already the anterior capsule is gone and you end up with a dislocation. I have had the opportunity to go in and do the repairs later on. Somebody did a radial relaxation and the head came out and the elbow dislocated, and went in, had to go in and repair it in 3-4 times. So that's one thing I can say, that even if one has done a excision of radial head, do force the elbow out, see that you are not having a dislocation, and if you are having, do repair it, at least repair the capsule anteriorly so that you not end up with a dislocated elbow after 2 days, 3 days in a post-op X-ray.
So thank you everybody. So Samarth sir was finally summarizing everything, Samarjeet sir, that you have to prepare beforehand, that you keep your things ready on your table. Even if you're going for a radial head excision, get your things ready, check it out on a stress views. If you require, do it there and then. Otherwise, Samarjeet sir has to do all this work later on. Okay, so we'll finish it off our discussion. A few 3-4 points for a general practitioner, Kotwal sir, where we should not miss, where we should not do. So that point, sir.
Right. So I would like to really congratulate all these speakers. They contributed significantly good lectures. Let's talk about the first lecture about the dislocation elbow. The important thing here is that most of the time, the reduction of the dislocation is not always done under anesthesia. It's done in the casualty and this thing. So the important thing to see is that after you have reduced the dislocation, whether the joint is congruous or not. If the joint is congruous, then obviously the ligament injury is not major. But if the joint is not congruous, that should give you a suspicion of some complex ligament injury, and which must be investigated and then repaired, as we just now talked about. The second one about the radial head fractures. The major radial head fractures can obviously easily be diagnosed on the X-ray, CT or everything, but you don't do an CT in a very simple sort of and very undisplaced radial head fracture. And there the tip would be that if you see an elbow injury and there is the X-ray doesn't show any fracture or anything, apparently at least, then you should try to look for, as somebody also mentioned about it, but I'd like to highlight that, you should look for the rotation of the supination and pronation. If there is limitation of rotation of the supination or pronation, that actually should make you suspect that there may be some radial head minor fracture or something. Get a CT scan done. And I also seen cases recently where it turned out to be there was a fracture of the radial head, although it was undisplaced, but it did cause, because of the pain and the fracture, it did cause limitation of the rotation. So that is another important thing. About the fracture dislocations, Samarth really presented very difficult cases and well operated and with good results also. Here I would like to say that the coronoid process fixation is important. That actually gives to the stability to the elbow in the sense, otherwise it will get dislocated anteriorly. And if there is in 1 or 2 cases, there was this type 2 O'Driscoll fracture of the coronoid process, which obviously was fixed, but that is the one which needs fixation to give stability to the elbow. About the approach, if there is a radial head fracture, this also Samarth also said, if there is a radial head fracture, then you can go easily through the lateral approach, because you work through the fractured radial head, repair the coronoid or fix the coronoid, whatever, and then can tackle or fix the radial head. Otherwise, buoyed approach, the posterior one is good. It's a little technically demanding because, the exposure actually that to go onto the medial side or the lateral side is little more. But otherwise, if there is no lateral fracture or the radial fracture, then you can even go from the medial side also and approach the coronite, which is not so difficult. Through the just anterior to the ulnar nerve, you can go approach and fix the coronite. It is important to take the coronite to its seat, its site. And as Dr. Samarjeet also said, so bring the capsule. Many times it is important because you may not be able to hold a type 1 coronite fracture very well with your suture. So take the suture through the capsule and try to pull it out and bring it and put it into its bed. And the radial head replacement, there was people facing difficulty. Everybody faces that. So a tip there can be that try to excise the neck of the radius within the permissible limit. You can do a little more because many times it is only through the fracture, and sometimes initially we keep struggling only through that window of the radial head fracture. So you can excise it a little bit and give a valgus strain. So that helps you to do the reaming through the radial neck and be able to place your radial head prosthesis. Thank you very much. I think.
Thank you very much, sir. Thank you. These points should be helpful to us. Thank you, team. Thank you, presenter. Thank you, everybody. Everybody has done so well. Samarth has posted his message. All was done exceptionally well, brilliantly well. All teams done very well. Thank you, everybody. So I pass on my mic and the final comments to Dr. Shekhar and Dr. Atul sir to just close off this session. Thank you very much. Thank you and good night from my side. Right, sir.
Thank you so much. And I'll request Shekhar to please give vote of thanks.
Thank you, Pushkar, for organizing the show. It was done brilliantly. All the topics were very simple and very relevant. And these are very common topics. The treatment which we discussed here were to the point, and especially the importance of CT scan was very well highlighted through the cases. Many times in simple cases, we think that let's we just manage with the X-ray, and during the surgery, we are surprised with the kind of fracture which we see. And that was highlighted very well in these talks. Dr. Kotwal, as expected, he brought out the salient points of each talk. And we especially thank him for chairing the session and giving us his wisdom. Thank you, sir. Thank you very much. And to all the speakers who worked on their talks, who labored hard on their lectures to give us some knowledge. Dr. Samarjeet was there with his practical tips, the problems which we face actually on the table when you have limited resources and how to manage it. So thank you, Dr. Samarjeet, with your comments. So again, from DOA, we are very thankful to all of you. Big thanks to OrthoTV who have been with us for all this series, and Dr. Ravi Chauhan, who is the intermediary between DOA and the OrthoTV. And he's also the convener of these webinars. So I think by the end of this month, we'll have another in this series. With this, I thank you very much. Thank you.
Thank you. Good night.
Thank you, sir. Thank you.
Everyone, good night.
Good night. Good night, everyone.
Good night.
Thank you very
Thank
much.
you, everybody.
Night.
Good night.
Good night.
Thank you so much.
Rishi, we can end the meeting today.
Debriefing after the meeting.
Rishi, are you there?
Hello, sir.
Yeah, are we offline?
No, it is still recording.
No, sir, we are live, and I'm ending the live now, right now.
Please stop the live
Stop
stream.
recording.
Are we offline, Rishi?
Yes, sir, we are offline.
Thank you. Thank you. Lalit sir, please go ahead now.
Thanks, Ravi. Thanks a lot. Excellent session. Thanks, Dr. Atul and Dr. Shekhar.